So I want to thank everyone for joining us today for the first of 5 sessions on the future of primary care in BC. For those of you that don't know me, I'm Veronique Siufi. I'm the racial equity researcher and policy analyst with BC Policy Solutions. We're located on the unceded stolen territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And for those of you that may not be familiar with our work, BC Policy Solutions is a progressive policy research institute, and we're looking for those redesigns that are going to make life in this province better, healthier, more sustainable, more affordable, more just. So we've got a team here. We've got economists calculating how we can better redistribute wealth and how investments in public and social infrastructure, are not only the right thing to do, but better for balancing those, budget sheets in the end. We've got social scientists doing community-driven research. We also act as a hub for cross-collaboration across community organizations, nonprofits, academics, and the labor movement. And of course, we also try and make all that work that we do accessible to all of you, like what you're tuning in for today. So this series is going to teach you about a great example of how when we design public systems with equity in mind, meaning, when we make sure our systems work for the most marginalized, they end up working great for everyone. So this requires, really clear values-based guidelines, some community responsiveness, stable funding, and that we stop treating our public services like market businesses. But I'll let Marcy take that part on from here. If you don't know her already, you're all very lucky to be joined by Marcy Cohen today. Marcy has a long career in research, which is focused on public policy solutions to the current challenges in our healthcare system. She's worked for the Hospital Employees Union. She's worked as an adjunct faculty member in the health sciences at Simon Fraser University and was a longtime board member and chair at the now closed Canadian Centre for Policy Alternatives BC office. We're lucky to have her on our board at BC Policy Solutions. And if you sign up for our newsletter, you'll get to see her latest paper on how BC can and must do better with primary care, which is coming out soon. So I'll pass it on to Marcy now to chair and get us started with our first session on the future of primary care in BC.
Thank you, Veronique. Really wonderful to be here. I feel really privileged that BC Policy Solutions has taken this on at this moment. It seems to me like such an important time when there's so much uncertainty and so much what's going on around us in the world. And in terms of healthcare in BC, we just hear over and over again about the problems and the challenges and how difficult things are. And we all need these public services and healthcare public services more than ever. And so I am so happy to be able to be facilitating this group where we have people who are working on the ground to do things in a way that's actually working effectively and really is a way of looking forward about what we need to do better in our system overall. And each of these are organizations and people that are here come from different kinds of not-for-profit team-based primary care organizations. And so this is about, and the whole webinar series is about the importance of this kind of a model being an important sector within the whole primary care ecospace that is relatively new and that has a lot to offer. So I'm going to just say who the 3 different types of organizations are here. So the first is Shoreline, which is Leslie, and I will do a more full introduction just before the questions, but Shoreline is more of a physician-led, team-based primary care, not-for-profit. Melinda is from a not new, but the longest lasting and oldest community health center in the province, REACH. And Leah is the executive director of Kílala, which is a Indigenous-led primary care, not-for-profit, team-based organization. So you can see different types of perspectives, but all coming together and in terms of what they're doing in their communities to create a more integrated, accessible, prevention-oriented system of primary care in those communities and with those people. But also, I'm hoping that we can look at this as a spark for the future, sort of thinking about if these kinds of organizations were better supported to work more collaboratively with the rest of the primary care system, with health authority run primary care, with walk-in clinics, with patient medical homes, with solo and group physician practices, so that we were actually creating what many of us have yearned for many years, which is an integrated system. And system is the main word of primary care in local communities. Okay, so that's kind of who we are. I just want to say a bit about the research that anchors this initiative, this webinar series, and this work is very much wanting to put research more at the center, practical research that makes a difference. So grounded in the work of Barbara Starfield, that's kind of our Northern Star, and it is really the foundation of all primary care transformation internationally. And that was because in the 90s, she did some research, led this research project, very large project, that compared countries and looked at those countries that had strong primary care systems, that understood primary care as the foundation of everything else in the health system, and found that those countries that did that had better health outcomes, less medication use, more health equality, and lower costs, everything that you would ever want. It's not easy to move in that direction, and she defined 4 pillars, which I'm going to explain. And in BC, we have, in words at least, adopted those 4 pillars, but we haven't fully realized them because I think we haven't had that learning system research focus, and that's part of what's in the paper that I'm writing that goes along with this series, talking about that. But let me just say something about the pillars, because they're useful to know when you're listening to what each of the other speakers is saying. So first is comprehensiveness. So care that's not just physical health, but mental health, that's not just illness care, but prevention and wellness care, that's more holistic. And to be more holistic, you need to have a team. You can't do that with one kind of practitioner only. And secondly is coordination. So coordinated with primary care, with the other parts of the health system, with with hospital care, with home care, with specialist care, but also with community services for those people who need access to the more basic social determinants of health. So both the traditional health system, but the broader social support system. And then thirdly is longitudinal care. And this means that you know and have a strong relationship with your primary care provider or providers. And that makes a huge difference. That trust and that knowing each other and that being able to have that relationship, evidence says results in better health outcomes, better adherence to treatment plans, medication use, prevention, et cetera, et cetera. And then, of course, last, and the one that we're having the most difficulty with is access. So that the first point of access needs to be that longitudinal care, where the entry point is, that's your entry point into the health system, and that is available to everyone when they need it. The last thing I'm going to say in this sort of introduction is that what the research evidence shows over time is, and this is mostly from the States, where they're not-for-profit primary care health systems have really focused on these Starfield pillars. What they have found over time is that there is a need for everyone to focus on social complexity. Those are the people, when they're not properly supported in primary care, that are most likely to end up in hospital, in emergency room, with care that's much more expensive and much less effective. And that chronic care management is a bigger portion of all the care that we do. It's not just about the higher needs, few people. It's about all of the care for all of us. All physician practices have people with these kind of complexities. And there's an equity dimension here, as Veronique mentioned, is that chronic conditions are more likely and much more severe in people who are low income and have low social status. So we have to focus on equity, because focusing on these people is actually what's going to help make the system work better. But we've got to set up a system that does it so that it works in a way for everyone. And I'll go back to that at a little bit later in this presentation. So just now, some quick introductions. So first, Melinda, who's the executive director of REACH. She has a master's in public health, working in a leadership role in the city in public health, and was also the executive director of Community Action Initiatives, which is a grassroots provincial organization supporting mental health and substance use. So that's Melinda. Leah is the ED of Kílala, the Indigenous-led health and wellness clinic. She has a background working before she was an ED here, and she's their first ED. She worked at UBC in the Center of Excellence on Indigenous Health. And Leslie is at Shoreline, and they run 2 clinics on the Saanich Peninsula. And Leslie was an ED in 3 different divisions of practice in North Shore, Nanaimo, and South Shore, South Vancouver Island, and is also has been an RN for more than 40 years. So you can see this panel has a wealth of background and expertise. And with that introduction, I'm going to ask the first question, which is to get started. I want each of you to talk about your clinic. Give us a little picture of what it looks like, who you serve, how you've evolved over time, what your values are, how the staff make all of this happen, just to present a picture so we can get, it comes alive and people get a sense of who you are. And I'm going to begin with Melinda and then move to Leah and Leslie. So over to you, Melinda.
Okay, well, thank you. Thank you to Veronique, and thank you, Marcy, for the introduction and for inviting me to be part of this conversation. I'm going to talk about REACH. So we are a community health center, and we've been part of East Vancouver for 55 years. We were founded in the late 1960s by Dr. Roger Tonkin and others who really believed in something that was quite radical for the time. And that was that healthcare shouldn't just treat illness, but rather should really respond to the conditions that shape people's lives. So right from the very beginning, REACH kind of pushed back on the idea that health starts and ends in a clinic room. Things like housing, income, culture, language, belonging, those were always understood as part of the health story. And I would say that that founding belief still very much guides us today. So at REACH, we have a medical clinic. That's where the longitudinal care happens, an urgent and primary care clinic, a dental clinic, a pharmacy, a whole suite of programs designed to address the social determinants of health. And these live in our health equity and engagement department. And I will say too that we are the only community health center with an urgent and primary care embedded in our organization. And in that space, we work with a simple mantra, thanks to the medical directors, and that is care and connect, care and connect. So that means we're not just addressing the immediate need that's right in front of us, but we're actually actively working to attach people to make sure that they get the care that they need. So our attachment numbers here are very strong. Our clinicians carry balanced panels. They include people from the broader community alongside folks with more complex needs. So the community that we serve is quite diverse. It includes newcomers and immigrants, people who have a precarious immigration status, the Indigenous community members here in Granby Woodland, seniors, youth, and folks who are living with chronic illness, also alongside poverty, trauma, and exclusion. So, as you might imagine, for many of the folks that we serve, access isn't just about getting an appointment. It's also being shaped by whether or not the care feels safe, whether language is a barrier, whether people trust the system, and also really whether their lives are allowing them to show up at all. So I would say that who we serve at REACH really shapes everything, and a standard approach just would not work for our community. In terms of values, culture, and kind of how the team shows up, so we're community-led and nonprofit, which really matters deeply. It allows us to focus on the community that's here and the unmet needs. And I would say that our org culture is very relational. I imagine you would hear a lot of that in the nonprofit sector. We believe health happens in the context of relationships. So, of course, with patients and families, but also with community and community partners. And that shows up in our team-based care model. So alongside family physicians, nurse practitioners, nurses, we have social workers, counselors, pharmacists, cross-cultural health promoters, super important part of our model, peer, lay, and volunteer navigators. We have the dental folks. And of course, there is a strong administrative and operational staff group who are often that sort of first point of safety and then also continuity for folks. So just in terms of culture, I would say care is not something that we deliver to people, but rather it's really something that we're building with them and with community together. So in terms of access here at Reach, we're low barrier, we're that trusted place to start. For many patients, Reach is really the first place that they feel safe kind of entering that front door to the healthcare system. We do spend a lot of time, I would say, coordinating across hospitals, with specialists, with community organizations, also with various different ministries. And I would say too that this is not an add-on to the work at Reach, but rather this is something that is really and truly our core work. So that continuity piece that Marcy was talking about with respect to the research, it just doesn't happen by accident. It needs to be done by design, and it happens really well if it can be done through meaningful relationship. So I think I would just wrap up my answer to this first question with what REACH shows is that when primary care is rooted in community and relational and allowed to address the realities that people live with, so those conditions that shape health, the social determinants, it really naturally aligns with what the evidence tells us works. And I'll talk a little bit more about how our structure supports that as we move through the conversation in a little bit. Thanks.
You.
Thanks, Melinda. You're so inspiring. So I just want to honor everything that Reach does, and you certainly are a pillar in our community. I'm Leah, and I'm the executive director of Kílala Lelum. And Kílala Lelum, we've only been in existence for 7 years now. And we grew from a place of some of our care providers have worked in the downtown east side, which is where we're located, which I call the epicenter of colonial harm, where it is, of course, one of the poorer postal codes in Canada. And we work with community members that have experienced many colonial harms. We serve about 80% of the community that we serve is Indigenous, and many have very complex health challenges that they're facing. And so some of the care providers that we're working with that have been working in this community for a long time felt that the usual family practice model, while good, wasn't adequate to address the needs of our community. People might come in with some really deep pain or some mental health challenges, and while a physician was able to sit with them and to be able to prescribe appropriate medications and perhaps triage them, they weren't able to look at some of the other determinants, such as, food insecurity or poverty or lack of employment or disconnection from culture or from home. And so the understanding in particular for the Indigenous community, my community that we're serving, is that they wanted a connection to culture. They wanted a connection to elders. And there was a small research project of bringing elders in to support Indigenous residents. And some of the patients had that experience and wanted more of it. So we created a model of care that incorporated elders and knowledge holders as part of the model of care, as well as other allied health professionals like social navigators and counselors and outreach workers and community health workers and food as medicine managers and food security. So all of that wraparound came together. And the other thing that we really wanted to do was to create health equity, like thinking about our family as our relatives, our kin, our community members in the downtown east side, and how do we want to take care of them? What kind of care do they deserve? What kind of care are they not getting? And so we were particularly responding to the TRC calls to action 19 to 23. And so that meant that we wanted to have Indigenous leadership. So that comes in our board structure, as well as our community advisory, of course, because so much of our community is made up of Indigenous folks that come into the clinic. and as well as our lead structure has at least 50% Indigenous leadership here. So we wanted to marry both Western medicine and Indigenous medicine because we knew that a partnership between those things could do magical things. And so that's what we've been able to do. And some of the complexities here are incredible. And so that people are walking alongside with, they have opiate use disorder. Our members have depressive use disorder with chronic pain, alcohol use disorder, PTSDs. Those are the top, when we evaluated, those are the top health concerns that our members brought into our clinic, and that's what we see. So we're working very holistically to address some of those concerns. So yeah, we've been around for 7 years, and we really feel like we're just getting going. Thanks.
Thanks, Leah. I'm Leslie from Shoreline Medical, and I'd like to speak a little bit about how Shoreline has grown over time because it's driven by community needs and remains community focused to this day. We're a charitable, registered charity nonprofit, and we began back in 2016. We're on the Saanich Peninsula in southern Vancouver Island, which is kind of northeast of Victoria and quite a rural area. The society itself was developed in response to a significant number of family physicians that were set to retire. And not only did they provide primary care, they're the folks who worked in the inpatient services at our local, fairly small community hospital. It's got 48 inpatient beds. And so without action by the community, there would have been a huge vacuum and a crisis in health that people were facing. So what started then with 5 family physicians and 1 clinic has since grown today to 25 primary care providers. 2 of them are nurse practitioners. We have 2 primary care clinics, one on either side of the peninsula, and a dedicated youth clinic serving close to 16,000 patients. And the variety of medicine that providers practice is important because our patient population spans from the very young through to the elderly, and to provide the kind of comprehensive wraparound care that Starfield refers to. Physicians provide inpatient services at the hospital for assigned and unassigned patients. They do fast track and emerge, so the kind of CTAS 4 and 5. We have physicians that provide maternity care, palliative care, long-term care, and of course in our youth clinic. And the services really ensure that there's continuity between hospital to community and the other care environments. And we were an early adopter of team-based care, and it not only helps in sharing the care amongst the staff, but it also helps with the administrative burden that we all know is a well-known stress point among providers. In terms of the values, I think, that guide our work, first and foremost would be community commitment, in that we're responsive to what the community needs. So an example of subpopulation we provide services to is our youth clinic. It's the only clinic on the Saanich Peninsula for youth, and we offer primary care, mental, and sexual health counseling. We receive a tiny bit of physician sessional funding from MCFD, but the rest is entirely supported through donations and grants. And in that youth clinic, there's a leadership track for youth peer mentors who receive formal training in mental health and sexual health. And what that does is it really helps the youth clients feel more confident in speaking to healthcare professionals about their choices once those appointments are made. And just as an aside, the last graduating cohort of 10 youth mentors, because they graduated from high school last summer, they've all gone on to post-secondary studies in healthcare, which is, we think is really cool. The part-time coordinators in the clinic are those people that really build and cement the relationships with the middle and secondary schools and promote the free services that we offer at the youth clinic. One of our medical directors at one of the clinics is also the MSA president at the local hospital. So, very connected with physicians who practice there and aware of what's needed to provide that continuity of care. We also have 3 specialists on site who our providers can refer to. We have a psychiatrist, a physiatrist, and most recently, as of last month, a pediatrician. And I would say that the culture is very people-centered, where staff at all levels feel empowered to do their best work, and the care is compassionate all the way through the team. And as Melinda described, we also have a strong leadership team. They're lean, but very efficient in what they do. So we have an operations director that ensures standards are similar across our clinics. We have a billing manager that handles all of the MSP billing, including rejections. So taking that admin burden away from the providers. We have a couple of HR professionals who are responsible for hiring, training, and supervising staff. So again, the physicians and NPs don't have to do that. And then, of course, the clinic managers and the medical office assistants.
Okay, that was wonderful. So the next question is like sort of the core question of this webinar, which is, so why nonprofits? What difference does it make? And how has that made all that possible? And why is that structure so necessary? So who have I got first for that? I've got Leah, and then Leslie, and then Melinda. So Leah.
Thank you, Marcy. You know, I don't think Kílala Lelum would exist if we weren't a nonprofit, because we could not imagine what we could create without having a nonprofit structure. So we came to be with a grant, with the help of VCH, absolutely, with some of our food and wraparound care for those with HIV or at risk of HIV. That was one, but it was really the substance use addiction program through the federal government opportunity to apply for a grant that we imagined our model of care. And we applied for that grant, received that grant, and we piloted having elders as part of our model of care. And so we evaluated our whole system and looked at what we could do. And we found that having elders as part of the partnership improved people's sense of well-being as well as their health outcomes, and lessened their emergency room visits by 15%. With having elders as part of our care. And so that became part of our model. And then when the second call came to be, we were able then to start a chronic pain program. And our chronic pain program with a physiotherapist and an exercise therapist, can you imagine what that's like for people in our community that very rarely have access to health, don't trust the healthcare system, to be able to alleviate their chronic pain, some of their issues and concerns. And so that has been an amazing innovation that we've been able to have here at this clinic. because we're a nonprofit structure, we could apply for some of these grants and create these incredible models of care. And our model has been our practice, and so and then creating the evidence base in order for us to apply for sustainable funding. So the challenge, of course, of being a nonprofit is that sometimes the systems aren't able to support all of the innovations that we have, even though, for example, the chronic pain program, we found that people's pain scores decreased by 50%. And so they had less opioid use using days, which was pretty significant and a really wonderful way for us to feel like not so helpless in the face of the toxic drug crisis that we're facing right now. And so, and our big challenge, of course, is now we're on a financial cliff because that funding is ending soon. But being part of a nonprofit as well as First Nations Aboriginal primary care network that we collaborate with really has enabled us to innovate.
Thank you.
Yeah, I wholeheartedly agree with you, Leah, in terms of the benefits of being a nonprofit, in our case, a charity. Our board of directors volunteer their time, and there's 12 of them, and they basically set the organizational strategy and ensure the financial health of the organization, of course. And our directors are actually a mix of community members and family physicians. And in our mind, it really offers us the best of both worlds. So we maintain that community connection, and the work is informed by experts in primary care, the family physicians. And so the structure itself then provides relevance both to our community and to our providers. And being a registered charity provides us with many benefits that we wouldn't otherwise see. So we're able to raise funds through private donations. We can apply for grants for programs and equipment that simply would not be possible through the revenue generated by overhead, which just covers the kind of rent and the staff and the basics. And some examples for you, we can raise funds specifically for physician and staff recruitment and retention incentives. We can direct funds specifically for clinic enhancements. And one of the examples I provided earlier is the fundraising for all of our operating expenses for the youth clinic and the programs within that. When we're working with municipalities, because we're in two separate municipalities, we're able to apply for permissive tax exemptions. And should they step further into the fray of supporting primary care, much like what you see is happening around the province in some municipalities, they are able to offer grants to us for things like tenant improvements or facility space at a really nominal fee. And those are not possible for-profit private business because the municipalities are restricted by their charter. I think being a charity seated in and driven by the community, we're already functioning as a natural hub for patients that need services from across the health system. So a natural partner to collaborate with and, really build on what's already going well. So, for example, we have two family physicians and a midwife who are providing maternity care. And what would round out the program beautifully is if we were able to partner with a public health nurse who could assist us in running group medical visits, speaking with parents about, the care for a newborn, what to expect as new parents, and the importance of vaccinations, what that schedule looks like, the bonding between parents and babies. Currently, we're limited in the mental health counseling that we can offer in our youth clinic simply because the funding, um, restrictions. And we're all, I think, patently aware of the demand and need for those services, particularly in the youth sector. And essentially, the demand is just outstripping our supply. The Some cuts that have happened recently to Island Sexual Health, they used to partner with our clinic and lost a significant amount of their funding. So they're not able to offer the same level of service they were before. And sex health educators for this population are vital. And I think that now that our PCN allied health resources have been distributed throughout our PCN, I wonder if the next area of work for PCNs could include an assessment of services available from health authorities, cancer agencies, diagnostics, and community agencies to coordinate and partner with primary care clinics for particularly for people who are more complex and there's a need for those preventative and specialized programs. And I think alleviating that coordination role in some way for these from primary care could ultimately improve access to primary care providers.
Thank you. I believe it's over to me to build on that. I'm going to start in terms of the nonprofit structure question just by stating at the outset, like there's this idea that there's like the health authority, and then over here there's reach. I just want to say like we don't exist instead of that system or on the outside of it, but rather we exist within it, and we're very much in partnership with it. The Health Authority, Vancouver Coastal funds just over half of our work. So in terms of our total org funding, it's about 53% at reach. And that funding is truly essential, and we really appreciate it. It allows us to deliver publicly funded universal primary care as part of the broader system. When I think about what would be the not-for-profit advantage, I would very much echo what Leah and Leslie have said about our ability to use our dollars in a way that is responsive to the specific communities we're serving. And so in some ways, I also think about that as talking about permission. So permission to organize ourselves around community need rather than something that might come from outside of community as a particular mandate. So I think that piece is really important. And our governance structure matters so much because it literally determines, like in a way, what we're allowed to care about. I don't know if that's the right way to say it, but it's our board is accountable both to the place and to the people in this community. So I think too that because of that accountability to place in addition to people, it gives us permission to hold that wider definition of health that we're really talking about here in terms of those determinants and the conditions that shape people's health. Having worked, I worked in the health authority before coming over to Reach, and so I would say the values are not different. The commitments are definitely shared across that public healthcare system. But what feels very different to me is what we're structurally allowed to act on. So I think being place-based and human scale is really central to this. At Reach, it feels like we're small but big. We're small enough to be in real relationship that's meaningful with community members, with grassroots orgs, with cultural and language-based partners. And I would say too, because we're close to community and so embedded, the patients are on our board, community members are on our board. We see and hear things early. And so one example I have of that is when several pregnant women showed up at the UPCC, our urgent and primary care, positive for syphilis in the span of a few months. We saw a whole bunch of this, and it really felt like it was a bit of a canary in the coal mine, signaling that the system itself might not have been catching those infections early enough. And so when that's caught late, it has really significant impact in terms of risk that's higher for both parent and baby. And this, because of who we serve at REACH, it's very clear that this is due to structural barriers. So things like immigration status, lack of primary care attachment, poverty, language barriers, fear of systems. And that's who we serve. So we were able to work in collaboration with public health folks at BCH and also the BC CDC to figure this out. But part of this story is that those were mostly folks who didn't have MSP, but who knew they could come to REACH and felt safe and know that they were going to get the care that they needed. So I think our structure in many ways allows for that. I'll echo some of what we heard Leah and Leslie say about how we finance ourselves. So I feel really fortunate to have joined REACH and to have two thriving social enterprises. So alongside that health authority funding, we also have a dental clinic and a pharmacy, and those are very successful. Any excess revenue that generates from those two clinics gets put back into REACH to help fund the equity work that we do. And it very much is an important funding component of our health equity and engagement department and all of those programs. We do work with like 20 or more different funders in the granting space. And that's across like health, mental health, settlement, employment, all the things. And it's very, I will say, administratively and operationally heavy for sure. But at the same time, having those diverse funding sources is what gives us some room to move and stay nimble because we're not wholly constrained by the priorities of any one funder. So I think I have time. I'm just going to share a brief story that illustrates this well. I think several years ago, there was a man who arrived at REACH who was fleeing war. And of course, we see lots of this, unfortunately. When we met him, though, he was cycling through emergency rooms, and that's how he was getting his care. So obviously, that's the most expensive way to engage with the healthcare system. He was living with trauma, experiencing homelessness, and then also had to navigate serious legal and mental health challenges. And at that point, was not allowed to see his young daughter. So what that showed up and how that looked in our clinic was anxiety, depression, missed appointments. But really underneath that is just someone whose life is like, and their family had come apart. And so what I wanted to share is that in many settings, that would have been broken into short episodes where you would have had 10 counseling appointments over here and a few sessions over there, and maybe a referral to something else. And each one of those things would have an end date. And they might be ending even though things would still potentially be getting harder for the individual. So at REACH, we were able to respond differently and the counseling continued. Medical care, primary care was just connected all the way through because a lot of this is happening in a wraparound way, like right on site. Social work, cultural support, harm reduction, legal advocacy, and later as this person stabilized, they were able to participate in a program called Links to Employment, which is in partnership with CMHA BC, and that helped him rebuild a path back to work. So I just want to say, all of that was happening not over weeks or months, but really over about 5 years. And today, this person is housed, working, connected with their daughter. And at one point, they even told our counselor that they hope to invite him to his daughter's wedding. So it's just a beautiful story, but unusual, I think, because often those folks fall through the cracks. So I think it's not that our model is better, but just about recognizing that this complexity really requires complementary structures that aren't hierarchical, but that are collaborative. And so when we can align with the other pieces of the healthcare system, then people don't fall through the cracks.
You're muted, Marcy.
You're on mute, Marcy.
Sorry, everyone. Yeah, very inspirational stories. Thank you all. And it is kind of what keeps me going is hearing these stories and learning from these people. But I just here want to just make a couple of comments because it is so different than what is possible under the business model. I mean, it is, though regularly physician practices are small businesses, and they just do not have the community mandate or the legal structure or the organizational capacity to take these initiatives. And yet they will maybe have patients who need some of these services as well. And so it talks about the value of having a system of care and coordination and having a strong not-for-profit sector that can support and work with others in the primary care space. And I just want to give an example that I just learned from Ontario when talking to our next webinar participants, where they said that in Ontario, they have this very ambitious attachment initiative. And one of the things they're doing is making multidisciplinary staff and prevention-oriented staff working for and with physicians that have no team members to help them with their people who are medically or socially complex. And seeing that as attachment, because it's taking the load off the physicians who can't actually address all those issues and making it possible for them to attach more. So I just encouraging people to listen to the Ontario example at the next webinar, because it's so good in terms of showing the way and the way in which they are using the not-for-profit sector in some very innovative and important ways right at the center of their system. So we're going on to our third question, where we're going to talk more about some of the challenges. And I just want to provide a bit of context here. So I want to go back to when BC first talked about primary care transformation in 2018, and the vision was to move from physician only to team-based care based on Starfield. It was the primary medical home was to be the team-based care, and it was supposed to be the kind of cornerstone of an integrated system of community and primary care. But there's ways in which it was introduced without the learning system or infrastructure that really supported what it means to shift to team-based care in an effective way. And I'm sure some of you, the panelists, will talk about that. But what I want to do is quote from the BC Medical Journal, just to give a sense of the fact that the inadequacies of where we're going is well recognized by many in the system. And that is that this was a recent article and saying that despite a lot of spending on the longitudinal compensation model, the LFP, we still have way too many people who do not have timely access, and are still using virtual care or walk-in clinics or emergency rooms. And that means that, they're not getting care as effectively, that matters as much, and is of course more expensive. We said that before, but they also note that we do need more team-based care. So these are coming from, when they lead off, there was a physician. There's a recognition very generally that we can't stop moving towards team-based care. And so I just want to have that as context for the next questions, which is two ways I'm asking to look at the shortfalls that we have now and how to think about them. So the first is how are the existing resources we have, how could we use those more effectively? We're spending quite a bit of money. How could we make sure that we're using that most effectively? And secondly, where do we need to invest new money that will in fact result in a more cost-effective system? So I'm going to ask each of these panelists this question. I'm going to begin with Leslie, and then Leah, and then finish with Melinda.
Yeah, thanks, Marcy. I wanted to start off with something that's positive in the sense of the things that were put into place into the primary care system. On the South Island, we're starting to see that the investments made are having an impact on physician recruitment. And so that's a positive. When I speak with our local physician recruitment lead at the South Island Division of Family Practice, she said that clinics are actually running out of space to accommodate the increasing influx of physicians. And I suspect that the interest she's seeing in physicians from the US is based on the political situation down there, which of course none of us were able to predict. And there also remains a very strong interest from physicians from the UK who are dealing with job uncertainty, job security issues over there. So just wanted to start on that piece. But in terms of barriers or challenges and things that we could overcome, one of the benefits of something called the new to practice contracts, which I'm sure the audience will be familiar with, for newly minted physicians, carried with them the incentives that could pay down the enormous student debt that many of those physicians carry. And they also provided guaranteed monthly overhead, predictable overhead for practices. It's been a very successful program, and I don't quite understand the reason for the NTP or the new to practice contracts not continuing in their former state, because as we continue to grow, population continues to grow, we're going to need more primary care providers to meet that population demand. The second point that I wanted to make is that providers and patients have tremendous appreciation for the allied health professionals who have come to us through our local primary care network. And I think something that would greatly enhance those teams is if they were able to work to their full scope of practice. So, for example, an RN can run a code, but in a primary care clinic, they can't pair a wart. And that then falls back to the primary care provider. If we have social workers, and if the social workers were able to complete forms on behalf of physicians, or at least assist them in starting for disability, income assistance, insurance, would take a huge administrative burden off of the providers, thereby increasing access. And I think if training is the issue, which I've heard that's part of it, training everybody up to the same level, perhaps we could look at community clinical educators for each discipline, much like what they do in hospital. And I understand that the certification of nurses to work in primary care is something that's in the offing, but in the interim, I think we could work together to enhance what the allied health are currently able to do. I think the other thing is to think about in the future of primary care investment is the FTE component of allied health professionals that's currently available. So for our clinics, probably similar to the others on the panel, each clinic are appointed zero point 0.2 of an FTE of each of those allied health providers. And you could imagine if we could increase the FTEs along with that full scope of practice, the impact that that would have on access, health outcomes, decreased visits to emerge, and decreased expense to the system overall. And when I look at the healthcare alliances in Ontario that you referenced earlier, they're making great strides in prevention through focusing on the social determinants of health, not only navigating and sourcing those services, but coaching patients how to use them. And I think we could take a page from their book in looking at what might be possible in BC. Something else related to allied health is the need to increase the overhead that's provided when they're co-located with clinics. So we have, like others, we have fixed costs of rent, insurance, EMRs, maintenance, all the rest of it. And those costs don't change based on who's sitting in the seats. So the clinics need to be fairly compensated for overhead costs to make the programs sustainable. Something that I mentioned previously is to fund and mandate PCNs to take us up a level in the coordination of health and social services with primary care clinics to provide that wraparound care for patients that are needing those interventions. And I think lastly, the PCNs received funding that was determined necessary for allied health at the time that the proposals were sent to the Ministry of Health, and then PCNs were subsequently implemented in our community. But with the population increasing and the complexity increasing, that static number of FTEs provided the demand is already outstripping the supply. So kind of what's next? And I think we need to continue to build for a growing and increasingly complex population.
Leslie, I would just echo everything you just said. I think it's absolutely so. Certainly the contracts that we have right now support it's actually been we're so grateful for the new primary care contracts. The big thing that it doesn't help fund always, and VCH has certainly come to the table for that, and that's been really wonderful. But we still are short funding for nurses, and we are short funding absolutely for allied health professionals such as counselors and social workers. And those basically come out of other grants, and those grants are very soft. And of course, we know that this is a time of fiscal restraint, and so we've had some clawback from VCH, and as well as we've had some cutbacks even from the FNHA, and that was just a small grant, but a really critical grant to help us with this. And so we're now thinking about and working overtime to figure out how are we going to address those gaps for our community members that have incredibly complex challenges. I guess the other thing, certainly in our PCN, because I am fortunate to be part of a PCN that is Indigenous led, which means it's the host nation clinics as well as the urban Indigenous led clinics, Anya, Luma, ourselves, and Vancouver Aboriginal Health. We all come together and collaborate because our focus is mostly the Indigenous population in Vancouver, knowing that REACH takes care of many of those members as well. But the people that come to our areas in particular and the complexities that we're working with here. So I'm really grateful that we come together for that, and that has enabled us to fund an elder FTE for our clinics. However, it does not actually include an allied health care provider, and I think social navigation, social work is really important for our population. Yeah, thank you.
Thank you. It sparked so many of my thoughts. I have a few ways to answer this question. One of them is definitely along the same lines in terms of the type of funding we get and the way that it comes to us. And Leah, you just made me think of a story about how because the Granby Woodland population of Indigenous folks is 8%, and actually 8% of the patient population who are attached at medical are Indigenous. And we used to have this amazing program with an elder in residence, an Indigenous knowledge keeper, an Indigenous health promoter until the grant money for that ran out. And of course, when we compete for grants, they do prioritize Indigenous-led organizations and initiatives as they should. So it's very difficult for us to find the money to sustain something like that. But as you can imagine, we build all of that trust and work so hard to stand something like that up, only to essentially just have what feels like the rug pulled out from under it when you can't sustain the funding. So that is definitely one of our main strategic priorities, the board and myself and the leadership team, is to find a different way to fund some of those positions because we do need them. I will say on the funding, it's a lot of course, time and energy trying to cobble together and stitch together all of this funding. You end up reporting across multiple different systems, with the trickiest one being some of that federal reporting that we have to do. And the funding models that support team-based care, like the way I view it, are very limited because they don't include our cross-cultural health workers and they don't have sort of like a broad definition of team-based care. But if you're going to be equity-oriented, those are the folks that actually really help with access, with building trust, with coordination and some of the stabilization pieces. Because as well, some or a lot of the bigger multi-year dollars come to us and they're based on year-end funding, but they were never a permanent line item in anybody's budget. We're about to lose two very significant grants. One is through Community Action Initiative, and this is for community-based counseling. So it's free or low cost. At Reach, it's free. They fund several grantees all around the province. They've been funding us since pre-COVID, but now there's no more year-end money for that. So it's pretty tragic. We have two Spanish-speaking counselors that were really hard to recruit, and they've built these great relationships. And that money is set to run out. And then we found out on Friday that MSDPR can no longer fund nonprofit dental clinics across the province with the operating grant that we have all relied on forever. So it's just cut, just gone. So I do think these are huge challenges. Marcy, I just want to quickly respond to that extra part of this question that you said about where would we invest or what could we do differently with new money. One thing that we're talking about is how much complexity there is, and we're working downstream, like with the impact of systems that don't serve everybody. So one thing that I've long wished for, I wished for it when I was at VCH in public health too, though, is just a clearer shared responsibility across sectors. I went to a really cool conference in Atlantic Canada once where the Minister of Health says to her ministerial colleagues, "You are all the ministers of health," because health doesn't live just within a healthcare system by itself, but it's held collaboratively. So I just wanted to say that too, that shared responsibility across sectors is so important. Yeah.
Yeah, thank you all. So we started with talking about how positive things were, and we've ended up with some really sad barriers that are you cut those things that are not funded permanently because they're easiest to cut. You haven't made a commitment to them, and they may be the most cost-effective, evidence-based programs. And we can't continue to work this way. We can't continue to make every innovation temporary and not have any process for making those long-term based on evidence that they are the ones that are making the difference. And so we have to have just much more of a evidence-based learning health system approach to everything. And so in terms of that, what I want to say, I mean, none of us are going to give up and none of us are going to stop doing this work, but there is, coming up a budget. We know that budget is the reason why a lot of these cuts are happening. We know there's probably more cuts coming, but we also need to, and thank goodness for BC Policy Solutions that is looking at the fact that there is room to generate more revenue if we compare ourselves to other provinces, including Ontario, to spend money. And we have to look at, surely we need to spend more money if it's going to be more cost effective in the long run, because otherwise we're just down this very negative tunnel of responding to a very negative world, and we have to rise above that. And so I just wanted to encourage people to listen to that work coming from BC Policy Solutions, and for that also to be something that carries us forward in terms of doing the work, and to know that there is interest, like so much interest in this webinar, interest from health authorities, interested from people in leadership roles in family practice, interested from community organizations. There's a lot of us who really want to see these changes, and there's some encouragement that came out of the CARGA process, with the Greens just saying to community health centers that you matter, and we need to really do something that's broader that pushes that forward. So with that, I'm turning it back to Veronique and the questions, and we're sorry that we not have more time for questions, but this was wonderful. Thank you to all of you panelists. I've loved working with you. It's been a wonderful experience and much appreciated.
Thank you so much, Marcy, and to all our panelists. There's a lot of interest in the Q&A. I think to try and stick on the positive note that you're trying to keep us on here, Marcy, because there were a lot of questions around the relationship between public funding and the not-for-profit model. But maybe to keep things positive, I'll ask, do we see a future where this can be the standard public model, this not-for-profit team team-based care approach. After hearing a little bit about the precarity of trying to piece together grants, can we see this being the standard publicly funded model? Maybe I'll start with you, Marcy, but we can pass it to the panelists.
Yeah, I mean, I think it's really a different way of conceiving not-for-profit and understanding it as an extension of the public system and more accessible and lower barrier, and it contributing to what it isn't as easy for health authorities to do, or isn't as always easy for physician clinics to do, that low barrier community safety. We're not the system, we're helping you, we're part of the community, and understanding that is a real value. And too much of the time, nonprofits are looked at the cheaper alternative, right? And so you have all kinds of challenges because they get paid lower. And if you think of the nonprofits as extending the system and valuing those services and raising them up, you can obviously do a lot better at managing, and that is the cost effectiveness issue around particularly people with higher needs, that otherwise end up in crisis and in emergency because there's nothing else for them to do. So I do think there's a different way of thinking about it. And I think that, it's also an issue in childcare. It's an issue generally that not-for-profits play such a crucial role, but have too long been seen as a cheap alternative. And that's not just what they are.
Thank you, Marcy. Panelists, do you want to jump in on this? Can you see this as a wider, publicly funded model? Why don't we have more of these? They sound great. Yeah, Leslie, go ahead.
Yeah, I think, I mean, the answer is yes, but what it will take is commitment to do the right thing, like recognizing what these nonprofit models can provide and recognizing where the shortfalls are that we've all described. And, it's from my perspective, when you talk about primary care, often it's looked at from a shortage problem, like there's not enough workforce, really not enough physicians, not enough nursing practitioners, not enough of appointments. But really, I think what it comes down to is that it's a problem of not being organized. Like we have all of these resources, but we don't yet have a system in place where things are truly integrated. And I think that in and of itself would save a huge amount of money if we were able to use those systems and services more effectively.
And
Yeah, Melinda?
I think I'm maybe saying somewhat of the same thing, but if you keep equity at the center, I think I tried to describe this like a very traditional model just will not work to meet the needs of folks who have like negative access to the determinants of health and who are marginalized and who I think we heard Leah say in a really good way, like just don't trust a mainstream or a much more institutional way of doing things. And so I'm not saying that there needs to be a nonprofit community health center everywhere, all over the place, and that's the only model, but rather there's no hierarchy here. It's not necessarily one is better than the other, but it's like, how do we come alongside, be valued equally, not as the cheaper alternative, but as offering just as much quality in like a health ecosystem, like where we're just all, and in that sense, I think the coordination is so important. So I do think we need more nonprofit centers because they can respond to what different communities need. We just heard about how different the community that Leah serves is, that Leslie serves is, that we serve is. So you don't want to stand up a whole bunch of same cookie cutter models. You want to actually stand something up that the community can help plan for, can help lead, and that is really responsive to different communities. And I think that's where the nonprofit model with wraparound supports fits really well.
Yeah, I'll pick up on the coordination bit in a second because I saw a few questions around PCNs, but maybe I'll go back a little bit to the question around the role of doctors here. So I did have a few questions about, in this model, are doctors going to be paid less? Is this a matter, Leslie, you touched on this just now, is this a matter of a shortage of doctors? Do we need to be looking at credential recognition or being able to transfer licenses from other provinces? Like, this kind of doctor-centered approach to solving the problem. Like how I was happy to see some comments from Doctors of BC interest in this team-based care model. So maybe could you speak a little bit more to the role of doctors in advancing this nonprofit team-based model and what it looks like for them working in this setting? Yeah, Leah.
I mean, I just want to raise my hands up to the doctors that I work with in our system and model of care because, of course, in the early days when we were trying to do as many MSP billings and finding it absolutely inadequate when you're sitting for a half an hour working with somebody, you're not going to be moving people through the clinic really quickly, especially if you're doing relational work that is attending to them. So I think it's really important to ensure that you're efficacious in your care, that you actually are responding to what is in front of you and what's needed. And I think most doctors feel really dissatisfied if all that they are is writing a script and that's it, and having to do it in quick succession and unable to actually be part of a team that is taking care and supporting a patient in their hopes and dreams wherever they are, So I think it's important to have doctors alongside as part of it. And of course, it does seem that the model is very centered on physicians because those are the contracts that get supported first. And I totally respect and appreciate that. We need their medicine. And there's other medicines that are needed as well. And so I would love, if I were to advocate for anything, is to strengthen the medicines of addressing the social determinants of health, the care of our nurses, the care of other providers that really support all of the things that our community needs. And so, I mean, our governance structure is set up so the doctor is not the only voice. We have a leads table. We have leads in every sector and every team. So they're really important, but it's all of it. And I think it leads to higher, job satisfaction for everybody because you are part of a collective that's responding to the community.
Yeah, Leslie well, yeah, go ahead, Leslie.
Yeah, what I was going to say is I think the doctors of BC and BC family doctors and the Ministry of Health have done an excellent job in terms of the new compensation model for physicians. The LFP model is really helping to recruit and attract physicians to the province, but I don't think it's should it be physician centric? Should it be, otherwise centric? I think it's really that notion of team. So physicians and nurse practitioners provide primary care in their expertise. The rest of the team members, working to full scope are equally important. And it's really the team and the services that that team can provide that are going to best support the patients. And I agree with what I think it was Leah said about the social determinants of health. I think we pay far too little attention to that particular area of medicine that could really offset a lot of the problems that we're currently experiencing.
Yeah, Melinda or Marcy, did you want to jump in on this question around doctors before I move on?
I think Leslie just summarized everything that was just in my head after I heard Leah. So
I'm
yes,
good too.
team. And
Great.
it's like such a rich working environment. When we
Mhm.
do staff satisfaction surveys, like the people are here to help people, but they thrive here. And someone was like, what is this place? It's filled with magical unicorns. Like everyone loves working here. The team-based thing, even when there's moral distress, because there's a fair bit of that, but you're in it together, you're not on your own, and that makes all the difference for sure. Yeah.
Okay, well, maybe I'll bring it back around to the coordination question about this. So, Leslie, earlier in this webinar, you mentioned that you've got some extra admin support, and there might be costs associated with having this extra admin support, but that removes the burden from folks in the clinic from managing, MSP billing and all of that. So, maybe can we take a couple minutes to talk about the value of like these coordination roles, the role of the PCNs, the role of these administrators in lifting some of the burden off of what folks in the clinic have to do.
And are you asking me to answer that?
You don't have to, but you can
No.
start. Yeah.
Yeah, I think we kind of touched on it a little while ago. It's that when we look at patients, for example, their needs don't rest in silos. So, like if I think about our clinic, a youth mental health concern, a new baby, somebody that's dealing with frailty or chronic disease or has some kind of social instability or they've just been discharged from hospital, all of those things arrive at the same front desk and someone has to coordinate it. And if those services aren't coordinated through some kind of hub, then it's left to the individual people at the front desk. And I think when that organizing function that you refer to doesn't exist, the burden doesn't disappear. It just shifts to emergency departments, hospitals, and primary care providers who are already at capacity.
Yeah, Melinda.
Yeah, I was just going to jump in and say, sometimes when I think about coordination, a little bit like what Leslie said, like here's the person and they have some needs that can be met here that are clinical, but then they have all of these other needs to meet. And so at Reach, how we try to do that is MSDPR comes here and is literally like embedded here on the side of our waiting room every Friday for a certain, like, let's say 1 to 4 or whatever it is. So there's that with that sort of nice ministry relationship in terms of people having a chance to connect directly with those folks, but here in the place-based way so they don't fall through a crack. And then we also have a really cool program called Basics for Health. So it has one part-time paid coordinator, and then it has a group of what I will say are mature post-secondary students who work. They get trained over a certain number of weeks, and then they're here for whatever their volunteer length is. And they're really helping people with the MSP applications and with a housing application or with what like all of those other pieces are. So we do it in multiple ways. Sometimes when something's really complex, it's through the social workers, which we definitely don't have enough FTE of. And then sometimes it's with these highly trained volunteers, and other times we get the ministry to come right to us to help with some of those coordinating pieces, but they are integral. Like people don't have a fair chance to be healthy unless they can get these supports. They're just as important as the clinical pieces, right?
Mm.
Yeah. And I think that's the thing is you don't get funded to do any of that coordinating stuff. It's just we're expected to hold that on our own.
Yeah, Marcy, go ahead.
Yeah, I sort of want, I saw things about the PCN and I want to make some comment on it. And, I think at the very beginning, I was involved in discussions with the government. So this is at a different level, not a clinic level. I'm looking at it more of a systems level. And at the beginning of the primary care reform, I was involved with government in advocating for there to be broader representation from other than just physicians, for there to be representation from nurses and allied health professionals and from community. And it was rejected by the physician saying it's enough for us to get together, we'll do that later. And there are some places that have done that, but it's not built into the system. So it's going to be pretty hard to, so there's supposed to be a coordinating mechanism, but they don't have all the players sitting at the table with equal voice. Um, and um, and also they're really limited because they can't hold money. They're not nonprofits. Like they don't have, so they can't do a clinic is closing because too many retirements and they can't afford to keep their space. Well, unless you have a nonprofit that can be a backbone that can take that on and help them through the transition, you can't manage that. And if you're wanting to have any kind of stopgap measure of walk-in clinic, or you've got a number of attached people who are complex and you want to provide some service with them now. I know they're doing this in Kootenay Boundary where they've got nurse practitioners working with higher needs people who are not attached, that they can't attach. None of that can happen if you don't have a nonprofit. So there's limitations with the PCN process because it isn't a formal structure that can work like a not-for-profit. Plus, I don't think there's been enough advocacy and support for the benefits of them working in a more collaborative way. And that definitely is something that there needs to be more discussion about and change to. And I think it's going to be interesting to hear from people from Ontario because they didn't develop their PCN till later. And they started out with having this very strong not-for-profit sector, particularly the Alliance and those organizations related to it. And the Alliance for Healthier Community, which includes community health centers, it includes team-based family care, doctor-led, it includes Indigenous, it includes nurse practitioners. But they are now using the PCN as a coordinating mechanism. So I don't know that we necessarily have to throw it out, but we do need to change it in a way that it actually can be a part of solving this problem, which at this point, I don't think it is.
Mm. I'm going to ask you to answer this question very, very briefly, Marcy, but I do want to just quickly ask you to flag a little bit about some of the funding models that we're about to lose. We may see this reflected in the budget, but I know we're about to lose the population-based funding. Can you tell us just a little bit about this in a minute or two before we wrap up?
Yeah, well, just quickly, it's the one team-based funding model that we have. It's only in about 9 clinics. It's called a capitated model in other jurisdictions. And it does make it possible to have teams and focus on complexity. It's not volume-based, it's complexity-based and has those kind of measures. They've extended it until September. But we really need more than one funding model, or we need a funding model that works for teams. However we want to put it, we need that. And we need an evaluation before they drop the only team-based model we have. We need an evaluation of it, how it stands up compared to the LFP, and maybe not just in relation to the LFP, but in relation to other capitated models, and say, does it need to be changed? But how can we still maintain some kind of team-based funding model? Lots and lots of most have more than one funding model. We don't just need one funding model here in BC.
Thank you. Thank you for clarifying that. Okay, so I think that's about all the time we have for audience questions, but you guys have done a great job of, very succinctly addressing a lot of the questions that I'm seeing in the Q&A. But maybe what I'll do is I'll ask you each to leave us with, one final thought before I say goodbye to the audience. So, what's the last thought you'd like to leave with the audience, or what keeps you going in this? Maybe I'll start with you, Leslie.
Sure. I think that community-based nonprofit primary care clinics have really become quietly become the infrastructure that connects the health system to people's actual lives. And you've heard, Melinda and Leah, give some wonderful examples about that. But we recruit providers, we integrate allied health, we manage the transitions, we support prevention, we partner across sectors, and yet we're still funded as if we're only delivering appointments. And so the question I think I would leave the audience with is, if primary care is the front door of the healthcare system, are we funding it as a service, or are we willing to recognize and support it as essential health system infrastructure, because the future primary care may depend less on how many providers we train and more on whether we intentionally build and support community organizations that make coordinated care possible in the first place.
Thank you so much, Leslie. Melinda, do you have a final thought for our audience?
Yeah, I think I love what you just said, Leslie. I mean, a lot of what we're talking about is how do we keep health equity at the center? And I really think that the nonprofit community-based organizations are built to respond to difference, like in all of its beautiful forms. And I think that's what I've been trying to say throughout in terms of our ability to be responsive to the uniqueness of each of our communities. And we stay close enough to just adapt when people's lives don't fit some sort of a standard pathway. I'm not saying that it makes us better necessarily, but it makes us useful. We're such an important model. And so I think if we want primary care that like truly improves access and equity, and those go together, then we have to build it collaboratively. Like right now, I don't feel like we're meaningfully at the table in terms of that broader health system partnership, how the care is planned, funded, and delivered. So that's my dream. Be at the table, do it together.
That's great, Melinda. Thank you. Leah, do you have a final thought for us?
I guess my final thought is always thinking about who I am and who we are at Kílala, Lelum, and our responsibility to the Indigenous people here and the community at large. And I am driven, and we are driven by the health and equity, of course, that continues to exist for our community. And uh, it's been quite heartbreaking, quite honestly, that we were making some real inroads, and it seems since our primary healthcare crisis of COVID, which is now ended, but the toxic drug crisis that continues, the years of life lost for Indigenous patients is, at 10 years compared to the rest of the population of Canada. So I am driven for love and care of this community. And we couldn't do this work. And of course, for everyone, we couldn't do this work without collective support for a nonprofit, as well as all of us working together to address some of the challenges in front of us. So I really appreciate you and thank you.
Thank you so much, Leah, Melinda, Leslie, Marcy. You've been wonderful. This has been incredibly informative. I hope for the audience inspiring. I think we have a really clear mandate to organize around here. And, if you want to find out about how we have the money to fund this, which we definitely do tune into our post-budget webinar where we can give you a breakdown of, where the province could find the money to fund these kind of programs that would then, save us money in other places in the long run. So really appreciate everyone attending today. Thank you so much to our panelists for being here. And please join us. We've got 4 more sessions that'll dig into different aspects of primary care. We're going to learn from Ontario. We're going to learn from nurses and nurse practitioners. We're going to learn from folks in Oregon. We're going to learn about the importance of addressing mental health as part of primary health care. And so I highly recommend that you sign up for the rest of our series, and you'll always get the recording afterwards when you sign up. Thank you so much to everyone for being here today, and thank you again to our panelists and Chair Marcy.